You to the Evidence-Based Health Coaching, the newest trend in patient engagement webinar. The Rural Health Network is proud to sponsor this webinar that's being presented by Melinda Huffman from the National Society of Health Coaches. Before we begin, I'm just going to cover a few housekeeping things. Our presenter has asked that everyone have a scratch piece of paper and pen with them for an exercise she'll be doing during the webinar, which is kind of unusual, so we're excited about hearing what that might be. Also, if you have any questions, you can see there's a box on the right-hand side of your screen. Type them in there, and Melinda's going to leave 10 to 15 minutes at the end to address them. Let's see. I'd like to thank Dylan Horgan from AHI, who is our technical support for this webinar. Thank you, Dylan. And I would also like to announce that on February 10th, Melinda will be joining us again to do a webinar titled Managing Client and Patient Resistance. This webinar is what I've been referring to as getting patients from no to yes, and for that she's going to be interviewing Jessica Frazier from Hudson Headwaters and Brenda Stiles from the University of Vermont Health Network so that she can really tie in the local piece to the webinar and help us with the population that we work with. So if there's not anything else, I'll turn it over to Melinda. Thank you all for joining us this afternoon.
Thank you so much, Courtney, and thank you, Dylan, for being our IT support. Thanks so much to Adirondack Health Institute for inviting me to be with you today. In reviewing AHI services and the populations that you both serve together with their partners, evidence-based health coaching honestly seems to be a perfect fit to help you accomplish your mission and your goals. Healthcare providers are finally beginning to see that the primary answer to what ails us in healthcare today, other than the financial aspect, which we'll leave to someone else, obviously, is that we often leave the patient and family out of the equation. And you might be thinking, well, Linda, how in the world can this be? Everything we do is for the patient. It revolves around the patient. We have patient-centered care. But I submit to you, honestly, that revolving around the patient is exactly what the problem is. Our teaching and our talking isn't engaging them to act in their best interest. We have great staff, wonderful programs, beautiful teaching materials. We spend a lot of time on these things. But this alone doesn't actively engage a patient and family to act as taught. And today we're going to discover, just briefly in the time that we have together, we'll discover a little bit more about how we can really engage these patients and families to act in their own best interest. Next slide. The objectives for today are 3. Define evidence-based health coaching, explain why traditional methods have fallen short, and describe how, and we'll use the short acronym EBHC to stand for evidence-based health coaching, and describe how it actually works to change health behavior. Now, of course, within the hour, that is certainly not enough time to go into full mode training, of course, which can take several weeks to hours, but we do want to at least give you a good idea of what this is all about. Next slide. So our highlights for our discussion are going to be EBHC defined, an overview of these strategies, just simply an overview. We won't be able to hit on even all the strategies, but we'll hit on some. From a traditional approach to EBHC, how do we get there? And it's primarily through a paradigm shift in our thinking, number 1. And why don't people change behavior? That is something that we need to understand to help us move forward in implementing some of these strategies. And then we'll have just a small taste of motivational interviewing, which we believe is the foundation of evidence-based health coaching and what we're all about. Next slide. So what is evidence-based health coaching? First of all, it's skillful conversation. We have to understand that what we're saying and how we say it and what we help the patient to say really makes a difference in whether behavior change can happen. Now, we've never really worked from that idea before, but it has opened up a whole new area of focus for healthcare providers in helping patients to actually act. What is it that causes them to act? And we'll find out more about that today. Also, our clinical interventions. We can't forget our evidence-based practice on the clinical side, the things that we must do for those who have diabetes and those who have hypertension and so on. Those clinical best practice guidelines we all have. We know them very well. We implement them as appropriate to that population and for an individual as appropriate. But it's the skillful conversation of engaging that patient that we're going to focus on today that's really rather exciting. Skillful conversations, clinical interventions that are used to actively and safely engage a patient. It's all about the activity of the patient, what causes them to act, so that they will want to self-manage their conditions with the goal to improve their outcomes, lower their risk, of course, and to reduce the overall cost to the healthcare system. Next slide. Sometimes it's helpful to know what it isn't. What EBHC is not. It is not counseling, so don't be afraid that we're moving into behavioral health to the degree that we may become counselors. That's not what we're about. It's not about directing, and I would encourage you to at least think about the fact that that's what we've been doing for years. We, as healthcare providers, have been directing the patient. We've been managing the patient. With the patient, honestly, except for talking to them and at them, we really haven't engaged them into the picture. Next slide. So what is the premise of evidence-based health coaching? First of all, we have to understand and assume that the patient is truly the real change agent. We can't simply look at the patient any longer as a passive receptacle. We have to understand that it's through the social context of a patient's life that they're going to make decisions about whether to access the ER in the middle of the night, whether not to call the home care nurse, whether to present to the ER when in fact they could have gone to a physician's office or the clinic for an appointment the next day. They are the real change agent. And their values, beliefs, culture, faith, birth generation, they affect those decisions. So I want you to think in terms of the social context of one's life is how those decisions are made. What causes them to make that decision to go to the ER in the middle of the night instead of waiting? Is it only knowledge? I would submit to you it is not only knowledge. Then also, we've got to look at the paradigm shift. We've got to change our thinking from being a director role to that of a partner. And a partnership can actually change the dynamics of the patient-provider relationship and foster behavior change. The director role is one that we've taken for years. It's a do this kind of thing. We're directors because we've been taught to have the answers. We've been taught to be that expert in what you need to do to achieve optimal health, to remain healthy, to recover. We have been the director. So that role needs to change, and we have the way to help make that happen. Next slide. Let's first just briefly look at the clinical model of EBHC that the society has. This was the nation's first clinical model of evidence-based health coaching, and just very briefly what I want you to notice is that we've got the health coach on one side, which is, that individual is using evidence-based practice interventions, empathy, compassion, and health teaching, while the patient or the client brings to the table their health condition, their beliefs, their concerns, their values, their birth generation, their culture, and where we meet in the middle is to partner. I want you to just think in terms of a 50-50 partnership. This partnership has to be 50-50 in order for us to connect with that patient, and we're going to show you how. We'll be using motivational interviewing as the provider, while the patient and client brings forth accountability and self-management interventions. We're going to meet in the middle through, like I said, the partnering, through mutual goal setting, and using the client's agenda. When we use the patient or client's agenda, sometimes in the beginning, that makes providers very uncomfortable until they begin to feel comfortable in using the skills that are available in terms of the conversation. And I would submit to you that in all of our audiences that we discuss, they're all providers, we have a tendency to want to use our own agenda because of time. Let's face it, we've got a lot to do in a short amount of time. So we believe that to get that checked off, to get those boxes checked off, is moving us through in the way that we have to check off what's on our piece of paper for documentation. But I would submit to you that you are going to enjoy health coaching so much if you decide that you want to move in that direction. We've had clinicians say, for the first time in my entire career, have I felt like a clinician that is truly meeting the goal that we need to meet in this patient-provider relationship. Next slide. So let's just look at some of the strategies that we'll be just touching upon partnering and the patient engagement, how to do that. There is a skill of empowering that is very, very powerful, if I might use that term, in getting that patient to come into that 50% role, that 50-50 partnership. Guiding the agenda, safe goal setting, there's definitely skills involved with that. Facilitation through motivational interviewing. The whole key is, how do we tap into that patient's own motivation to follow through? How do we tap into that to make them want to act? Use of evidence-based clinical interventions, of course, for medical advice, treatment, or instruction. Use of empathy, compassion, and a lot of knowledge about behavior change. Next slide, please. So why has health coaching emerged? This is very interesting. Over the last, really, 5 years, we've seen an explosion, and it's only going to continue. It is certainly the trend for 2015 and beyond because of where we're moving in wellness and prevention, away from a medical model of sickness, if you will, to a model of prevention and wellness. And face it, our traditional models really haven't worked very well in the past. Sure, there's several things we've done that have improved outcomes, but look at our incidence of diabetes and obesity and other chronic conditions. They continue to rise, and we know that there are a number of variables that cause that, but we also know that maybe some of our teaching, it's not necessarily what we're teaching, but how we're going about doing this that is not helping to the degree that now we know it certainly can. We're going to actively engage them, and we're going to improve outcomes while doing it. Next slide, please. So let's look at the first, the very basic difference. In traditional health teaching, it's a do these things kind of approach. I'm directing and I'm managing you because as the expert, I've been trained to tell you what you need to do. And you go away and do these things, and you will reach your optimal state of health. Okay? But now let's turn that over on its head, and let's look at, first of all, what are these kinds of things that we're wanting our patients to do? Next slide. What are these things? All day long, we're teaching them. Vaccinations, clinic appointments, checkups, diet and exercise, medications, urgent emergent care, adverse signs and symptoms, and the list goes on and on. Next slide. And if you don't do these things, I want to ask you as an audience, and if you're sitting in small groups in various locations, how do we label those patients? Speak it out in the group. We all know what we label those patients and families as. Next slide. It's non-compliance. Non-compliance. If you'll click, Dylan, you'll see that word pop up. We've used that term so often that even now, our own primary payer, Medicare, allows us to discharge that patient if they're non-compliant with an advance beneficiary notice of some kind. And we're, quote unquote, off the hook, right? But I want you to think of non-compliance differently now. Next slide. There is a difference in traditional teaching that may have even created some of this non-compliance. Now, I'm not saying the ball is all in our court, but there are things we can do as we engage and in the skillful conversation that can cut that resistance, can lower those barriers that honestly we don't even know we're creating. Let's look at health coaching. It's a guiding and partnering kind of approach. What's the greatest concern you have about your health? I want to tell you just a brief story. I was in a huge audience in the Midwest, and as we were talking about this difference, one of the attendees raised her hand, and it was it was like 500 strong. And she said, now I know what happened with my husband. And I said, wow, is it something that you can share with the group? And she said, it's very personal, but I'd like to share it. And she went on to share this. She was an RN. Her husband, they were both in their 40s, newly married. He was a very, quote unquote, non-compliant diabetic. She had been hounding him and hounding him and hounding him about his diet, his exercise, his injections. He would not comply. She said, I just had a horrible time with this. And I just continued to kind of berate him over the head about this because I know what he needs to do if only he would do it. He'd also ended up having coronary bypass surgery. because of the diabetes and because of his noncompliance. She said, now I know what happened in the doctor's office. He went to his physician, and he came home and he told me, my physician asked me this question: what was the most important thing to me about my health and about my body? And she said, my husband looked at me and he said, I told my physician my impotence. That is the greatest concern that I have. And she said the physician looked at her husband and said, if you will partner with me in this, we will reverse this together. What was so incredible about that interaction is that that physician tapped into what motivated that patient to comply with the clinical intervention guidelines that we know, the things that someone with diabetes should do to get that diabetes back in control. And she said, I can tell you over the next 6 months, he was more compliant than he'd ever been. They got the hemoglobin A1C down to under 7%. She said, while we still have some difficulty, he is in control. She said, now I know what happened in that doctor's office. That's our main takeaway today, is that how we converse, what we say, how we tap into that patient's motivation creates that 50-50 partnership that will help them to want to act. Next slide. Let's look at an example of the differences. Let's say the patient with diabetes says, when you call for follow-up and she's talking to her provider, she says, I'll get there sometime, but this person rarely keeps her appointments. So how have we traditionally handled that in the past? You know, you really need to keep your appointments. Or if you don't stay on top of your diabetes, you could really lose your eyesight or even a limb. We want to right them. We want to correct them. We want to tell them, if you don't do this, this XYZ will happen. What we need to be doing in an evidence-based health coaching context is this, and there's many different appropriate responses for someone who makes comments such as these, but you know, you don't really get in to see us very often. Tell me, if you will, what keeps you from coming in? Next slide. So how does EBHC differ? First of all, it's a guiding and facilitating kind of relationship versus a directing and a managing. We're going to actively listen. We're going to empower that patient by giving them some control in the whole conversation. We're not going to be judgmental, and we're going to focus on the patient's concerns, just like we did with the patient who had diabetes. What was his number one concern? Say it. It was his impotence. He didn't say, it's my wife nagging me. He didn't say, I hate these injections. He didn't say, I don't like having diabetes. He said, my impotence. That's where the provider then worked from to help him get compliance and get under control. As we've directed and managed in the past, we give all kinds of advice, and face it, it's diagnosis driven. As a cardiovascular clinical nurse specialist for years, I could give you all the interventions that I wanted to be sure that got done because I was diagnosis driven. I did the talking, I used my agenda. That's not what I certainly do anymore. And the results have been tremendous. Next slide. Really, with engagement and self-management support, even the Center for Advancing Health says, even in 2010, that's 5 years ago, the patient's involvement in their health care, where we're giving information and advice, has to be in concert with the patient's needs and preferences. So please understand, health teaching does not equate to self-management. That's what we've been trying to equate, and it just simply doesn't work. Next slide. I want to ask you this. Who manages 95 to 99% of chronic condition care? Is it the nurses? Is it physicians? Is it payers? Who would you say? Next slide. It's the patient. It's that little patient. And we've said the patient directs that care. They are the real change agent. I want to bring this home by talking or asking you a question. How well is the patient managing himself today? Let's go to our first polling question. Please respond to this polling question. I don't always follow my doctor's treatment plan or prescribed medication. How would you answer that question? Select one of the following. I don't always follow, or I always follow, as a patient yourself. Okay, Dylan, whenever you have the responses. This is perfect. This is and the reason I say it's perfect is that if I can tell that you all are being very honest, and I have to also raise my hand or check the box that I don't always follow. So I want you to understand in every single audience, it doesn't matter if it's coast to coast or if it happens to be from Minnesota to Texas, every healthcare provider audience answers in the same way. And it reflects exactly what you see on the slide here, non-compliance. Up to 60% of patients don't follow treatment plans as ordered. 50% never take their medication as prescribed or start their regimen. There are reasons we don't do this. There are reasons we don't comply. I want you to just think of yourself when you think of reasons why you don't. I've got a prescription in there right now that I got over a week ago. I haven't had it filled. Why? Because I'm not exactly sure, based on what the provider told me and what I read in the directions, as to how I should best take that medication. So it's now, well, actually, it's been into 10 days. I haven't started the medication. I'm a healthcare provider. So I want you to just think of this. We are them. We are just like our patients. There are other reasons, all kinds of reasons why we don't follow through. Next slide. Why don't people change behavior? Dr. Susan Butterworth with the Oregon Health and Sciences University did a pretty pervasive survey with several thousand people. And these are some of the reasons they gave, the primary reasons why they don't change behavior. Now, I want you to put this in context of the kinds of things that we try to teach our patients and families to do, quote unquote, and why they may not be following through. Their values don't support it. They don't think it's important. They don't think they can. They haven't worked through their ambivalence about it. They aren't ready for it. They don't have a good plan. They don't have adequate social support. Now, I want you to look at all of these reasons. Wow, I can pick out one now. They aren't ready for it for my reason because I haven't taken my prescription, haven't started my prescription yet. But what underlies that not being ready? I've got to go back to my provider, ask some questions, and then I'll make the decision about following through. So what I do want you to look about here is what is missing from this list that those surveyed did not respond with. And I would submit to you that it is, I'll give you a clue, it's probably our number one intervention that we do with every patient, every time, every occasion, at least somewhat. If you're in a group, share with the group what you think that is. And I will tell you, it is knowledge. You don't see that on this list. And we're teaching at them, teaching at them, teaching at them. And that's how we're missing the boat in partnering. That's how we're missing the boat. Knowledge isn't on the list. And I would say, too, that we all know that we're in the information age. Even if you don't have a computer, as my parents don't for various sundry reasons, primarily healthcare, eyesight, and so forth, they know that I have one, and they'll ask me to look this up on online, and can I provide that information to them? Next slide. So I want to share with you that change is truly similar to an iceberg. Look at this iceberg. You see only a small bit is visible above the water. but the driving force is deep below the surface, where 85% of that iceberg, that's what's susceptible to the different currents and the different flow. So I want you to think of your patient as that iceberg. Unless we are partnering with them and using the kind of skillful conversation learned in evidence-based health coaching, we cannot possibly know what is driving their desire or lack of desire to act and to engage. Next slide. So let's quickly go through just a quick start of evidence-based health coaching. Next slide. Conversations with patients and some of these pitfalls to avoid. Many times we're not finding out what the patient already knows. And in EBHC, that is a critical point of empowerment for that patient. And it's wasting our time. If we're going into a lot of information that they already know about, wasting time. So we've got to use skills to find out what they already know. We're also maybe missing cues that suggest the patient's underlying concern. If that physician with that newlywed husband had not asked about the patient's primary concern, he would probably still be beating his head against the wall why this patient is not compliant. A young 42-year-old, they should understand the downside of diabetes and cardiac disease that's associated with it, and just keep pounding the pavement. But that's not what happened. He took a totally different approach. Pursuing our own agenda. Now, I know that providers, they typically, like myself in my practice, sometimes we get a little nervous. If I just turn this over to the patient, what in the world is going to happen with my time? But let me share with you, you're not turning over everything. It's how you use the skills in conversation to guide that patient where you would like for them to go. And not for them to go necessarily as much as have them say where they want to go. In the end, you're saving a lot of time because the outcomes improve. Your time on the front end as you begin to learn these skills may take a little more time, but I can promise you it will be so well worth it in the end. Many times we ignore the patient's beliefs and values, and that's the social context of their lives that we have got to work from. I read the most interesting article by Su-Yan Barrow about populations with disparities, and it was so interesting. Perfect in terms of evidence-based health coaching fitting in to that population group. She said, I think that we need to begin to emphasize the difference between individual patients rather than differences in groups of patients. And this is exactly the heart and soul of evidence-based health coaching. We're looking at that patient's individual situation. That's what's going to tap into their motivation, their own motivation to act. Not seeking the patient's perspective on the issue. Next slide. Motivational interviewing, there's an art and a science to it. There's been 30 years of the science plus and over 300 studies. Now we're beginning to look at motivational interviewing that actually came to us from behavioral health. But in the medical community, we ignored it for so many years simply because, well, that's behavioral health. That's from the neck up. That's not our mantra. Ours is the neck down. And even though we've had psychiatric nursing, we've had psychiatric medicine, we've had counselors who may be even part of our own teams, it's all about them using that. Well, you know, mental illness is a very important need. But I will say to you that all of our patients have the need of being our partner in order to help move themselves ahead in the proper direction, in the direction they're willing to go. And motivational interviewing is perfect for the clinician. As we go through some of the aspects of motivational interviewing, I think you will begin to understand why that would be the case. It's a collaborative, again, 50-50 partnership. And I want to say it's not 60-40. It's not the provider being 60% and the patient being 40 simply because we're the expert. If we don't engage them with that 50-50% kind of attitude, then we're missing what can truly help that patient move forward. It's a style of guiding through skillful conversation. It's the kind of things we're saying and what we get them to say that elicits and strengthens that patient's own motivation for change. It truly is all about the conversation. Next slide. Motivational interviewing, and I'm sure many of you have heard of it. It began in psychiatry for the treatment of alcohol addiction in the early 80s. But what was so important here in the work they were doing is that what Drs. Miller and Rolnick determined was that it got the same result as Alcoholics Anonymous and also in cognitive behavioral therapy. They looked at 3 different groups. But what motivational interviewing did do is that it had the same result in less time and at less cost. Now in healthcare today, that is huge. So you can imagine that it has taken on a lot of interest in the medical community. They're even now teaching physicians some aspects of motivational interviewing for that very reason. Evidence-based health coaching, we have users from all spectrums of the medical disciplines, nurses, dietitians, respiratory therapy, counselors, therapists of all kinds, physicians coming in to learn more about an evidence-based health coaching approach. It's not pure motivational interviewing because we know that pure motivational interviewing can take you all the way to a counselor side, but there's also motivational interviewing for brief clinical encounters that we will talk about briefly in a moment. That we take that part of motivational interviewing, we couple that with our clinical evidence-based interventions for the medical side, and we have what the National Society of Health Coaches calls evidence-based health coaching. Next slide. The spirit of this we've mentioned, but it's so important, it's worth reiterating here. How I am with people, what I say, and what I help them to say truly makes a difference in whether behavior change happens. And I know you think, wow, that's pretty strong, but Dr. William Miller, who was the originator of motivational interviewing in the early 80s, has shown over and over this truly does happen, and that's at the basis of the 50-50 partnership. Next slide. There's 4 guiding principles of MI. Resisting the writing reflex, which is so typical of what we do as clinicians, and I have to laugh because I'm laughing at myself. I used to do this all the time, and I was the best cheerleader you ever wanted to meet. I mean, I was cheering them on, but what I was doing with my patients was totally overlooking what was of concern to them. We'll show some examples of that in a moment. Another principle is understanding that patient's motivation. We've got to drill down to their dilemma. That physician with the newlywed, he drilled down in short order to what was interesting to that patient, to what his dilemma was. He was a newlywed. He had that dilemma of impotence that at that time was very important to him. The third item, we've got to listen. And I will share with you that I was not a good listener, and we have certainly had many, thousands of providers tell us, look, we don't listen very well either. And there's skills about listening that you can employ. And how do we empower? We'll even review some of those items. Next slide. So just what is the writing reflex? We talked about we've got to resist that. When decisions are difficult, we generally feel at least 2 ways about it. We've got an internal argument about it. Okay, for me, I would take that medication that is sitting there on my bathroom shelf, but I'm not really sure how I'm supposed to take this particular type of medication. That is an internal argument. I would exercise more, but I get home late at night and I just simply don't have the time. Well, I would eat better with my diabetes, but as a teenager, I struggle with that. All of my peers are eating. I want to be able to eat what they eat. It's the but in the middle that is a problem. And as providers, we try to correct or write our patients all the time. And what happens when you write them or correct them? Oh, but you've got to eat. You've got to get into this rate my plate. I'll make it easy for you. I'll be there right there with you. And we totally overlook what the real problem is for them potentially. But when we try to correct or right them, the reflex of that patient is they're going to take up the other side of the argument. That is of the science. So we know that the more we try to correct them, the more they're going to take up the other side of the argument. Next slide. So let's look at ambivalence. What I'd like for you to do is take your piece of paper that you have with your pen or pencil, and right at the top here you'll see behavior. I want you to take a moment to write in a behavior that you would like to change about yourself, or that you've wanted to change and wasn't successful. Take about 5 or 10 seconds to think about that behavior and write it down, if you would, please. Now what I'd like for you to do is, while you still focus on that behavior, I want you to write on the left-hand column reasons why you've stayed as is. Reasons why you haven't been able to change. On the right-hand side, I want you to briefly jot down the reasons you believe you need to change, why you need to change that behavior. I'd like to give you at least 30 seconds, maybe 30 seconds to a minute. I really want you to think about this as you write down the reasons for staying as is and the reasons you have for changing. Okay, we'll stop and move forward. I think what most of you may see is that you have as many reasons for staying as is as you have for changing. And the key there is that's what causes people to be stuck. I would do this except for that. So that's the nature of ambivalence. And the interesting thing is that ambivalence is natural in all of us. So we're already working from a human behavior standpoint, in fact, of being stuck at times with making a decision. Next slide. The other item we want to just briefly touch upon is active listening. Are you really a good listener? We need to strive to be interested, not interesting. Next slide. So how do we listen today? It's really purely only evaluative. We can speak approximately 175 words a minute. Next slide, please. But our brain can comprehend up to 500 words. So what happens? It leaves us time to multitask, be distracted, daydream, lose interest. It's something that happens all the time, especially if we're not in a private conversation. And even if you're doing a telephonic conversation, whether it's coaching or whether it's engaging a patient or talking to a patient, multitasking is a bad thing. We've got to cut out our multitasking. We've got to try to get in that private conversation, even if you're in a cubicle. Try to get headsets if you don't have those, and it's amazing how many people don't have. But we have to be able to listen. There are skills of doing that. What I'd like for you on your piece of paper to write down is our website. It is also on the last page of our handout, but it's nshcoa.com. We have a free downloadable, How Good of a Listener Am I? I encourage you to go to our website. It's on the very first page, and simply download that assessment. What's really telling about that assessment is that we also want you to download another copy where A person who knows you very well, it might, and who would evaluate you honestly, might be a family member, it might be a coworker, but have them also complete that assessment about how well they think you listened and compare the two. It's quite amazing what you might see. Skip the next slide. 10 active listening strategies, real briefly so we can move forward. Stop talking. 50% of the time the patient should be talking. Remember, we've got to establish that 50-50 partnership. If we don't, it's likely that that patient is not talking 50% of the time. So just remember, it's 50-50 as a partner, and they should be talking as much if they truly are a partner. Then that means we've got to go back and reevaluate. What am I doing that's not creating that partnership? Demonstrating empathy, eliminating environmental noise, staying focused on the issues, don't interrupt, be attentive to body language, be patient, acknowledge what you hear is what is said, seek clarification, and keep emotions in check. Cerebrally, that sounds, sure, Melinda, that sounds great, but there are skills you can employ with EBHC that will enhance your listening. Next slide. So how do we go about empowering? We've talked about empowering patients, asking permission, and the way we give information. Would you be willing to consider more information about hypertension that I have for you? Would you be interested in some information about? Do you have any objection to XYZ? May I give you some reading material about this or that? Instead of just immediately giving them, handing them information. I can't tell you how many patients that I, many years ago, just simply gave them information because it was something that not only that I felt like they needed. Remember what I said there, I felt like they needed it. They didn't tell me they needed it. They didn't tell me they knew or didn't know about it, but I made these assumptions. And the reason is I was directing the traffic. I was not engaging them as a partner. How do I give information? I want to respect what they already know by finding out. That is very empowering to someone that you are talking with. Have you had to deal with diabetes in the past? Let's say you've got a newly diagnosed patient with diabetes. Have you had experience with diabetes? Said in a very concerned way can help them bring themselves up. It can help elevate themselves in your eyes, and that's what is a real key for establishing that partnership. Next slide. Then we get to OARS. It is the core, although it's not all of the skills in motivational interviewing, it's the core. Open-ended questions, affirmation, reflection, and summary. And today, because we have short time, we will talk about how to adapt this. Next slide. The first thing OARS helps us do is to resolve some of that ambivalence we've been talking about. Drill down to the dilemma that's so important. Understand how the patient feels about change, develop rapport, establish that 50-50 partnership, and evoke change talk. Next slide. It's science that the more one talks about reasons to change, the more likely the patient is to change. The more one talks about the disadvantages of change, the more one is committed to just sustaining the status quo. And if we continually talk in a way that causes somebody to defend where they are, change is less likely to occur. Now think about this, and this is science saying this now. Think about what we just said a moment ago, that internal argument and the righting reflex. If I say to a newly diagnosed patient with diabetes, now you've got to get this under control. Your A1C is now at 9.5. You could lose a limb. You could now, and we do this because we care. We're concerned. But what happens is the patient is more likely to defend where they are than to want to come with you and alongside you. Oh, I've also said when it came to patients who were on diabetic diets, oh, we've got a great dietitian. She'll be glad to help you. You can do this. I know you can. Well, let me share with you. It's not about what I think they can do. It's not about me cheerleading. I totally was dismissive of their primary concern. So we've got to get back into looking at their concern and using skills to engage them as that partner to help move them along. Next slide. So I've been talking about the adaptation of MI for brief clinical encounters, and it's two primary items, open-ended questions and empathy. Next slide. It requires thought to formulate a response on the patient's behalf. It allows time for them to expound upon what they're going to say and allows them to reflect upon those feelings and their values. Remember, it's the social context of their life that they are operating from. It's not a prescription necessarily, it's not a diagnosis usually at all, but it's their feelings about it. Next slide. And this is how we can use open-ended questions to partner with them. Tell me what concerns you most, and I would encourage you, if it's this afternoon or tomorrow, one of the easiest ways you can start engaging a patient is just, let's start by just telling me what concerns you today about your health. What is the most important thing to you? And it may not be anything that we've discussed in the past, but tell me, what is it today? It's amazing what you will uncover. What do you think about your progress? Explain why you think, what you think is hindering you. How do you think this would benefit you? Those are the kind of, and we think that those are easy, but because we have not been asking in that way, these precepts seem very easy, but I can promise you that when you begin to use these concepts, because of how we engaged patients traditionally in the past, or should I say directed them in the past, you will find yourself reverting to traditional questions. Yes, no questions. Yes, no is not partnering. Next slide. And empathy. This is what is interesting about empathy. Some research shows that as providers, we think we show more empathy to patients than patients think we show. And what I want you to please try to remember, you know what has helped me exude more empathy now than ever, is not that I have been where some of these patients have been, because in truth, I haven't been in their exact place. And I think we all could say that. While I've experienced some things, difficulty with staying on a cholesterol diet, low cholesterol, low fat diet, exercising, that's general. But some of these things that our patients, so literacy level. Next slide. Next slide, Dylan, will show the polling question. How does EBHC work to change health behavior? Dylan, whenever you're ready, you can show the results, and I'll start at that time. Excellent. Engages through the social context of the patient's life. And the key, definitely you want to use empathy, but empathy doesn't motivate. Remember, we've got to find the motivation, tap into the motivation the patient has within. And we're going to be actually using empathy as one of those things, but we don't motivate. We tap into the patient's own motivation. The next slide, think about this. It's the truth we ourselves speak rather than the treatment we receive that heals us. Next slide. We have many people who will ask us, well, how do I develop these skills? How do I get the training for evidence-based health coaching? We do give group discounts. There's a convenient self-paced study that's offered by the National Society of Health Coaches. You can start anytime. You can start as a group. You can start as an individual. It comes with a program manual and CD, plus there's online study resources, and there's online testing and skills competency 24/7. Next slide. Email me anytime, or you may go through Courtney to contact me. I'm happy to answer now any questions that you might have. It has certainly been my pleasure. I hope that I've given you something different to think about that will excite you and that will encourage you to think about your patients in a way of a 50-50 partnership, and that there's skills that you can acquire. While not easy to acquire, it's only because traditionally we've been programmed to direct our questions and our thoughts at patients instead of partnering with them to drill down to their primary concerns that can help improve outcomes, help lower the cost, and decrease their risk. Thank you so much, Courtney and Dylan, for helping to present this today. I do hope that you all have found something very helpful, and think about the takeaways that you have today. And if there are any questions, please post those. If not, I would encourage you to post any primary takeaway that you've had where the audience can view those. Thank you so much.
All right, everybody, if anybody has a question on the line, I encourage you to please use the raise your hand feature, and I will unmute you, and you can ask Melissa directly your question. Melinda, I apologize. It's your question directly. Okay, Melinda, it appears on our end that nobody has a question at this time.
Which means you did a super job. Thank you so much. Before we close out, I just want to remind everyone that we will be doing the second webinar in this series on February 10th. And that's the one we're going to talk about getting from No to Yes. So if anyone would like to be invited to that, let me know. We'll be posting it on the AHI events and news section. Thank you, everyone. Have a great afternoon.